With more than 200 bones, around 600 muscles, and almost 1,000 ligaments in our bodies, things can get a bit complicated. Something that seems as simple as walking is dependent on much more than just your leg muscles. In fact, synergy between our upper and lower body parts is controlled by just two small joints in our lower back, called the sacroiliac or SI joint.
It is the joint that connects the sacrum, which is kind of in your buttocks, to your hip. And this joint allows your pelvis to bend forward and backwards and twist side to side. So it's a very, very important joint in the spine, or actually throughout the entire body. It allows us to really connect the lower back all the way down to our legs.
That's Dr. Nitish Barara, Director of Regenerative Medicine at the Virginia Spine Institute. He says that while the SI joint is important for bending and walking, it actually doesn't move much at all.
We don't want the joint to move too much. And if the joint moves too much, it's called SI joint dysfunction or hypermobility of the SI joint, meaning that the joint is moving in ways that we don't want it to move. So your pelvis is not aligned. And so a lot of chiropractors will say the patient comes in and the patient's pelvis is not appropriate. I need to adjust the pelvis. And that is because the SI joint is not moving appropriately. So if an SI joint moves too much, that's a problem and the spine can be out of line.
On the other hand, if the joint isn't moving enough or gets stuck, it puts added stress on the rest of your body.
And it's stuck. In those situations, instead of moving the joint forward, you're starting to put more pressure in the lower back, or you're starting to put more pressure in the hip because those joints now need to move forward to compensate. And when that happens, you get a lot of lower back or pain that actually comes from the joint itself.
Unfortunately, Barara says many people with SI joint dysfunction don't get the correct diagnosis.
I think it's extremely misdiagnosed and it's underdiagnosed. It's much more common than we're normally diagnosed. In some studies, it can account for about 50% of lower back pain. And it's much more in the female population than in the male population, but it's a significant amount of acute back pain. And it can also account for a lot of chronic lower back pain as well.
Which is what Catherine Butterfield had lived with since she was 13. Doctors told her that nothing was wrong, and she'd probably grow out of it. However, the pain persisted for years until Butterfield was in misery at all hours of the day.
I would drive to the grocery store and sit there in the parking lot with my heated seat on in my car. It felt so good. And I would look at all of these 80-plus-year-old people walking into the store. And here I am actually, I think I'm just going to go back home. I'm not going to go in. Everything that I had tried hadn't worked. And when you have so many doctors blow you off, you're kind of well, maybe it is me. Maybe I am making it up.
Sadly, Butterfield's experience is fairly common because of the difficulties of diagnosing SI joint dysfunction. Barara says a main challenge is the lack of imaging test options.
For example, if you look at the hip or the knee, you get an x-ray, and the x-ray will show arthritis in the joint or will show narrowing of the joint, and it will help us make the diagnosis. When we're looking at SI joint dysfunction, we're looking at dysfunction of how the SI joint moves or how the SI joint doesn't move. And so an x-ray of the SI joint or even an MRI of the SI joint will not be positive and will not show us something that will predispose us to thinking about the SI joint. So that's why it's difficult, because you can't really assess it on imaging studies, and it needs to be assessed by a good physical exam.
There are several maneuvers that can help diagnose SI joint dysfunction. Some actively put more pressure on the joint to see if the patient's pain flares up.
This is a test where we take the leg and flex it and abduct it. If the SI joint is painful, then that extra stress of the SI joint will reproduce their pain and actually potentially cause more pain than their regular pain. And that would give us a good indication that the SI joint is having some sort of dysfunction and is the cause of their pain.
When Butterfield was finally diagnosed with a hypermobile SI joint, she received prolotherapy, an injection treatment for joint pain. The average patient needs 3 to 6 injections. Butterfield received 38 when she was 20 years old. And though it helped for a while, the treatment stopped working after a year.
I think if I had had doctors pay attention sooner, that I could have done the prolotherapy and the PRP and that it would have worked. But I think I was at that point, I just have a high pain tolerance. So I think at that point I was just so bad that it was just a temporary Band-Aid. I honestly just thought like, okay, I'm one in a million. Like every time that I would talk to a doctor about it, they would they wouldn't laugh in my face, but I think they thought I was exaggerating maybe, or that I had a low pain tolerance. I don't know. No one really like took me serious. So I kind of felt like there was nothing to do and like this was just my life.
About 3 years later, Butterfield's physical therapist introduced her to Barara.
He was amazing from day one. And he basically just said that where I was at, I needed to do kind of the Mac Daddy treatment, and that would be the stem cell.
Stem cell therapy is a part of regenerative medicine. Treatments for an SI joint dysfunction vary case to case. But for someone like Butterfield with a chronic issue, Barara says regenerative medicine is the best option.
Regenerative medicine is using the patient's own body to heal itself, to heal its injured areas. So regenerative medicine is a fantastic way to get down to the root cause of the problem and get it to actually heal.
In most cases, Barara says the stem cells are harvested from a patient's bone marrow after it's processed. Doctors not only get stem cells, but also molecules called growth factors, which stimulate tissue growth.
And then what we can do is we can find those areas that are actually injured and that are damaged, and we can use our needle to re-injure the area. So we needle the area and we get the body to say, oh, we have another injury and we need to heal something. And then what we do is we place the stem cells with the growth factors right into the area of injury, and then the healing process starts. So we take the body's own inherent healing process that started because I used a needle to start the process of healing and make this a really, really great environment to heal with both the growth factors and the stem cells.
Once in the healing process, the stem cells turn into active functional tissue, and they also recruit other stem cells in the body over to the healing area. Before Butterfield received this treatment, her SI joints were moving out of alignment all day. But after the procedure, she was shocked at the immediate results. After 10 years of daily pain, Butterfield had finally found relief. And though regenerative medicine is a relatively new discipline, Barara says it's becoming a more mainstream treatment option.
Over the last 10 years, we've seen the use of regenerative medicine skyrocket. We do use it a lot in the treatment of ligaments, in the treatment of non-healing bone fractures. We see the data now. Much of the data with PRP, which is platelet-rich plasma, or stem cell treatment derived from bone marrow, has been shown to be more effective than the traditional treatments that we have out there. And so we're seeing it kind of revolutionize orthopedic and musculoskeletal medicine.
While it's not a complete fix for all situations, Barara says it certainly fills a gap for many conditions. He believes regenerative medicine will soon be standard care, saving physical therapy for very mild cases and surgery for extreme ones.
When we were using regenerative medicine 9 years ago, we were definitely doing things that nobody else was doing. And now if you look at the studies are coming out every day and showing the benefits of the use of regenerative medicine when you compare it to the traditional care that is offered. So I think in the next 1 to 2 years, those studies are going to become to the forefront and going to show that the current treatments that we have are inferior to the new treatments that are out there.
He says that regenerative medicine is currently being underutilized. While one factor of that is due to the cost, Barara says that overall there's a lack of education.
Regenerative medicine isn't taught in residency, isn't taught in fellowship. And that's because it's not covered by many of the insurances. So when you look at the way healthcare is delivered and in the residency programs and fellowships programs, the educational system hasn't really taught that. And what we're seeing is now that it's becoming more and more mainstream and more the standard of care, it's being introduced into these training programs. And that's why I think in the next 1 to 2 years, it's going to become even more and more the standard of care for treating musculoskeletal and other orthopedic conditions.
And though it took years for Butterfield to find regenerative medicine, the results have changed her life.
I don't have pain at all. Like when I think of what a normal human would feel like pain-free, like that's me.
I think this is just the beginning. I think what we have to offer right now is small in terms of what we're going to have in the next 1 to 2 years. I'm extremely excited about it because I have patients that believe that there's nothing else that can help them. And now we have this option to actually get nerves to heal, ligaments to heal, tendons to heal, bones to heal. So I do think it's going to completely change the way we're delivering care in healthcare and totally in medicine.
You can find more information about Dr. Nitish Barara, Catherine Butterfield, and all of our guests on our website, radiohealthjournal.org. Our writer-producer is Kristen Farah. I'm Reed Pence. Coming up next week on Radio Health Journal.
It turns out that we need about 40% of medical students to be going into primary care to really meet our needs, and the numbers are unfortunately, much less than that.
Why experts say primary care is a field in crisis.
Then, even with a growing awareness of mental health, researchers say our compassion for those with mental illness hasn't changed.
You can't increase the empathy of somebody who doesn't want their empathy to be increased.
All that and more on Radio Health Journal.
I'm Nancy Benson, host of Radio Health Journal. If you enjoy listening to Radio Health Journal, you'll also like our sister show, Viewpoints, which covers a wide array of topics from education to history to the environment. Here's a preview of what they're covering this week on Viewpoints.
We're in a unique market that is really expensive, and keeping affordability of new cars is out of reach of a lot of households right now.
The high cost of going green. Then,
can I keep my dad's skull after he dies? Can I give grandma a Viking funeral? What happens to an astronaut body if they die in space?
Answering the questions we all have about death. I'm Marty Peterson.
And I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Viewpoints on your favorite radio station and subscribe and listen to shows anytime on Apple Podcasts and Google Play.
And that's Radio Health Journal for this week. Follow us on Twitter, Facebook, and Instagram to learn more. And check Apple Podcasts, Google Play, and Spotify for a library of past programs. Plus, you'll always find previous segments and information about our guests at radiohealthjournal.org. Join us again next week for another edition of Radio Health Journal.